So we are live now.
Okay. Arpit has joined.
You have to allow Prashant to share the slide, please.
Arpit,
We are live. Yes, sir, we are live now, and Dr. Prashant has given the controls.
Okay.
okay, very good.
I think you can see my screen now. And
Yeah, we can see a
Can you-
screen, but we'll have a little opening and then
yeah,
we can go ahead. Yeah, that's it.
So let me start. Dr. R.P. Gupta, President, International College of Dentists, India, Sri Lanka and Nepal section, and Indian Dental Association, Chandigarh State Branch. Eminent speakers of the event today, Dr. Raghunath Pataya and Dr. Prashant, fellows from ICD International Head Office, members of the Board of Regents of ICD Section 6, Executive Committee members of ID Chandigarh State Branch, dear ICD Masters and Fellows, and dear colleagues from all across the world. I welcome you all to the fifth and the final session of the certificate program on infection control and occupational safety in dental practice, being conducted by a fellow Dr. Raghunath Pataya from US and Dr. Prashant, who has joined us in the faculty today, again from US. We have had 4 very interactive, amazingly well done sessions. We had exchange of knowledge. Dr. Raghunath Pataya had explained us so many practices and how we have to follow the protocols to avoid infection in our clinics. Now, for today's session, I hand over the proceedings to Dr. Mahesh Verma, Vice Chancellor of Indraprastha University, Delhi, and the Chairman of Continuing Dental Education for ICD Section, to take the proceedings further. Over to you, Dr. Mahesh.
Thank you, Rajiv. Good evening, everybody. It's again great pleasure to be connected for the last and the final session of practical dental infection control and safety. As you all know that in the last 4 sessions, we had varied topics related to infection control. In this week, we talked about concepts of dental infection control and what are the common infections which are faced in the dental profession. And then we, afterwards, in the second week, we talked about germicide, use and misuse. And in the third week, we talked about protection, PPE, air circulation devices, barriers, hand washing, etc. And the last week, we basically talked about water lines and how can we monitor sterilization and preservation of sterility using chemicals and what can be used mainly for the water line disinfection. So, one very important part of infection control is use of antibiotics. And you know that, many of us, we, use and abuse antibiotics and antimicrobials. And, these days, this is a big issue all over WHO, all countries, including India. There's just so much of emphasis of antibiotic stewardship. That means the awareness, how can we regulate antimicrobials use and, so that people are not unnecessarily exposed to antibiotics. And today we have, Dr. Prashant Haribabu, who is, who's very well versed in this area because, he has been specialty care director at Department of Oral and Maxillofacial Surgery at Missouri School of Dentistry in St. Louis, Missouri. And, prior to that, he did his DDS from University of Detroit Mercy. He did his MSD from Rutgers School of Dental Medicine. He also has fellowship in infectious diseases dentistry, and that's where his role comes here. He's also done residency in orofacial pain and TM disorders. Before moving to US, in India, he's done his MDS in oral and maxillofacial surgery from SRM University College and Research Institute, Chennai. So, this topic is so important, and I think overrides all the concepts and how we can take opportunity to prevent misuse of antibiotics, because it is said that in the last couple of years we've had very few antibiotics, new antibiotics. So if we misuse these antibiotics where these are not indicated, we are imposing a kind of uh, immunity. Immunity, that means the antibiotics will not be sensitive any longer. So to talk about it and to understand this concept much more, let us have Dr. Prashant K. Haribabu, talking about antibiotic stewardship. Over to Prashant.
Prashant, if you may permit, our President, Dr. R.P. Gupta, would like to say a few words before we can hand over the proceedings to you. Dr. R.P. Gupta, please.
Okay. Thank you, Dr. Rajiv. Good evening to all of you, sir. I wish to welcome all my viewers from different places globally on this concluding webinar series of infection control and occupational safety in dental practice. Your contribution to the program has given us a continuous support. Our sincerest welcome to Dr. Prashant Haribabu, a renowned oral surgeon who has joined from the USA, and he will speak on antimicrobial stewardship. Dr. Prashant is a highly knowledgeable and opinion leader in the subject of antibiotic resistance, which is the most hot topic to be included in the CD program. We are confident all our viewers will become richer in their knowledge on the concerned topic. Our gratitude to worthy speaker, Dr. Raghu Putaya, who may likely to join us, who is legendary update with evidence-based knowledge on the subject he has covered. Our gratitude to him. Our warm master, ICD Section 6, Dr. Anil Kohli, our counselor to head office, Dr. Mahesh Verma, chairman, continuing dental education, Dr. Rajesh Chandna, past president, ICD International, Dr. Rajiv Chok, Secretary General, ICD Section 6, had a pivotal role for the success of this program. We acknowledge Dr. Mahesh Verma for his excellent conducting the virtual webinars before, during, and with concluding remarks after each event. We are thankful to Dr. Mahesh Verma ji. My humble regards to my master's fellows and ICD board members and ICD members for attending these webinars. I just remembered a few names who have just joined. My special regards to Masters Dr. R.K. Bali, Dr. Hari Prakash, Dr. D.N. Kapoor, Dr. Pradeep Jaina, Dr. S.M. Balaji, our IDA past president and our executive committee member, Dr. Lahal, Dr. Gaba, Dr. Ashma, Dr. Vidyaratan, Dr. S.P. Singh, and all others. Last but not least, my heartfelt thanks to fellow Dr. Arpit Gupta, Secretary, IDA State Branch, for holding this webinar with full dedication. I am also obliged to Dr. Varun Bajaj for helping us at the back. Your feedback is important to enable us in improving our scientific program and meet your needs in the future. Thanking you all and everyone. Now over to our worthy speaker, Dr. Prashant.
Prashant, are you there, Prashant?
Can you hear me?
Yes, we can hear you now.
Yeah. Thank you, Dr. Gupta, for the welcome. Thank you, Dr. Verma, for the welcome. And thank you, Dr. Chug. And thank you all for having me today. It's good to see you all. It's been quite a while and on a long hiatus, so we've not met during the pandemic. So it's good to see you all in one frame on my computer. So I can't ask anything more than that. Yes, as Dr. Gupta and Dr. Verma mentioned, it's an interesting and an important topic, antimicrobial antibiotic stewardship, because I have lectured with Dr. Putaya for ICD in 2016 at Maulana Azad. During that time, when we spoke about antibiotic stewardship, it was just a formal, information that we shared with you all from a dental perspective or from a dental background. We did not explore too much into this particular stewardship. But in the last 5 years, if you look at the research data and internationally and in every country, the antibiotic stewardship programs have become a little bit more robust, and they've also become much more stronger because of the increasing alarming increase in the antibiotic resistance that they've been seeing in different groups of antimicrobials, not just one particular common group that we commonly see in the oral cavity. So it's kind of increased in different spectrum, which we didn't really anticipate. We only thought that, okay, as a dentist, we see most amount of bacteria, staphylococcus or streptococcus mutants would be the priority for us. But then people started neglecting the other bacteria in the flora, both in the oral cavity and in the gut. So they have started to propping up. So let me start off by talking about this first slide. So when I put up this first slide, not a very amusing slide. You can look at the view; it looks beautiful, amazing in the mountains in the Midwest of the United States. So my wife asked me, "Why are you putting this unamusing picture?" So it doesn't really share too much about this picture, just about the mountain ranges, right? But then I told her that we're talking about something that has grown, that is developed and grown among us. So if you look at the weeds around this picture, it has actually grown more than the bushes and shrubs, which we didn't really pay attention to. So it was quietly growing and among us, and then it's going to cause more problems. So I think I compare it to the bacteria that are growing around us. And for the last 1.5 years, we were so busy handling the pandemic and focused completely on the pandemic, we kind of missed out on certain aspects of bacterial growth, resistance, and strengthening the programs to control this particular situation. So I've just put up a presentation just to compile what has happened in the last few years, not going back into the origin of the stewardship, as to how we could improve it better in our practice. And from a dentist standpoint, or oral health physician standpoint, how could we handle this particular scenario and be effective in our care? These are my affiliations with the various universities and the hospitals that I work in St. Louis, Missouri. So basically, I'm in the center of the US, and you can see the big bent arch wire, like a dental arch. So this is the gateway to the west. So if you want to go to the west of the US, you have to pass through this particular arch. That was the symbolic resemblance or the symbolic reason why they built the arch. I feel like it's like they bent an arch wire that needs to go on somebody's mouth. So, and also the St. Louis is the headquarters for the American Association of Orthodontics. So maybe that's another reason why they had that. So I'm primarily a teaching faculty with the Missouri School of Dentistry and Oral Health, and I'm associated with the oral surgery department here, and also hold privileges with the ENT department at the popular, most well-known university, Washington University. And I'm also associated with the other hospitals in the neighboring, 4 other hospitals in the neighboring, the metropolitan St. Louis neighborhood. So let's look at this picture. So I see a patient who comes into our oral surgery clinic, and she's about in mid 60s, and she comes to us after her general dentist removed her teeth, and she did develop some pain and soreness and some swelling in that area. And it did remain, sore for more than 4 to 5 weeks. I would say more than 5 weeks. That's what she said. And she came over to oral surgery clinic, and she wanted to find out what's going on. So this is a patient who's actually been diagnosed with osteoporosis as a medical condition too, and she was taking some medications such as bisphosphonates. So for her osteoporosis, and the dentist had probably overlooked or not been prepared to get more information about that particular condition, and patient eventually developed some post-operative infection. So when we saw this patient and we wanted to manage with antibiotics, that's what is the major arsenal that we have against taking care of patients with a diagnosed bisphosphonate associated or a medication related osteonecrosis. Our antibiotics sometimes are not being effective. One, because of the medical condition to begin with. Two, probably they've already been used, been exposed to the same group of antibiotics, that is the penicillin. That's the first line of medication for this particular condition. And when we go back and treat it, and it becomes much more harder, much more cumbersome for the patient, and then we have to deal with other comorbid conditions because of the medical condition. So let's look at this gentleman. He was about 75-year-old gentleman. He had gotten all his teeth taken out to get some dentures to enjoy a beautiful set of teeth. Apparently, the area where the extractions were done did not heal up as it was anticipated. So he kept going to different dentists to see what was going on. Some people thought it was just a calculus that was left behind, and they started removing the calculus. So an imaging, basic PA showed that it was the alveolar socket that has been exposed. So after scrutiny, the patient says that, yeah, I've been treated for prostate cancer for the last 1 year, and they've been giving me, denosumab, which is a monoclonal antibody for this particular condition, and because of which the bone turnover is actually stalled, and because of which the immature bone is exposed, leading to trapment of debris, food, and then leading to a localized infection. So again, the same situation we face. We started using the empirical, broad spectrum antibiotic, and we could not achieve, reduction in the infection. It took a while for us to do it. Then we had to do a culture sensitivity. So why is this happening? So that's one possibility. What's going on is that clinicians, both dentists and physicians, prescribe antibiotics empirically, to not go into in detail to investigate what is the bug that is causing that, and rather, use the medication on a blanket, like an overall generic, drug to destroy all the bacteria. So that's one of the challenges that has been growing, in the last 5 years. It's been growing in the past, but last 5 years it's been growing. But some efforts have been taken to contain this or to reduce that. So the International College of Dentists has always, partnered with the U.S. The Centers for Disease Control to actually create a program for when to use antibiotics, or when antibiotics really work. So the program was Get Smart, and to know when the antibiotics work. So this program was in place, in 2016 when I was lecturing, and it has been. It's good to see that Dr. Putaya is actually initiating this particular project from a dental stream, from a dental field, not only from the medical side, from the dental side, and continues to go on. So let's see what are the timelines and what are the developments that happened in the past and in the future. So before we jump into it, so let's also know what is exactly an antimicrobial or an antibiotic stewardship. What does that mean? How do you define it, or what is that? Is that a kind of a big deal, like the picture says? So it's basically to promote, educate, and enhance clinicians, physicians, dentists for optimal selection and the appropriate dosage and the duration of an antibiotic. that provides the best clinical outcome, both in terms of containment of infection, both in terms of reducing the unwanted side effects of the antibiotic itself, by producing minimal toxicity, and and also the impact eventually leading to resistance, to see how low the impact could be to cause resistance. So why are we really concerned about this? I mean, what is the resistance that you're talking about? Is there a real resistance? What is the real problem? So if you look at the timeline, if you go back few, I would say like 50, 60 years back. So when they had the newer development of antibiotics, after the invention of penicillin, and newer generations of penicillins were developed and newer groups of antibiotics were developed, they had, they did have some newer drugs to take care of the resistance. So they, as and when they had a resistance, okay, they were able to have some other group of antibiotic in their arsenal to take care of the problem. So if you look at the timeline, 1935 to 2003, there were only 14 new classes of antibiotics developed. And in 1998, that was the last year actually, only 2 new antibiotics were developed that had 2 new independent targets. It was not like, trying to piggyback on the previous generation ones. So you can see that from 2000 onwards, we've been seeing a rising number of resistance in the especially the methicillin resistant strains of Staph aureus. So in the US, 60% of the ICU cases are reported MRSA, and that's a pretty big jump from from the last 20 years. And they tried to install programs. They tried to bring in effective protocols in the hospitals. They tried to bring effective systems like monitoring based systems. But still, we are on the back foot. We're struggling to take care of these resistant bugs because we did not make any invention in the next 21 years from 2000 onwards. So there are reasons for it. So one major reason is that the pharmaceutical companies think it's a lot of investment to do the research and development. So globally, only 8 companies have actually done research and development for getting new antibiotics in the last 21 years. So it's so expensive that they feel that once you develop and create a new antibiotic, the entire patent has to be sold on to make it more generic and more affordable for the common public to use. Because what's the point of having an antibiotic? It is so expensive that people can't afford to buy it. And then it's also it's an acute condition, right? So antibiotic is used for an acute situation. It is not like a pain medication where you can use it for a long-term usage, like chronic pain medication, or you have a chronic, like a neurological medication or some other medication that is used for other conditions where you use that medication on years to come. So the pharmaceutical companies are pretty, economic focused, that if I create one antibiotic today, that's going to last for only a few years. Until that, they're going to get a resistance, and people are not going to buy those particular medication after 2 years because it's going to be resistant. So I spend millions of dollars investing in doing an R&D to bring out that medication, but then within a few years it becomes generic. I have to sell the patents, and then I have to go to a different group. So it's a loss of motivation for the pharmaceutical companies not to develop the newer generation of antibiotics. So it is actually a troubled sequence when you look at it, because antibiotic resistance is happening left and right center, not only in the healthcare sector, it's also happening in non-healthcare sectors too. So let's look into all those things in this particular presentation. So this particular data, where 50% of the antibiotic orders in the US hospitals were considered to be really unnecessary. So this was a study that was done in 2007, showed that they did not require that particular antibiotic. And again, thanks to programs like the SMART and Sentry, which is a study for monitoring antibiotic resistant trends, that actually provided these data to us. So that's an important tool, I think. So every country has their own SMART system. So every country should share that same system to the clinician, because they need to be aware, they need to be shown how their way of practice is impacting the society at large. So that's an important point to be instilled in this particular juncture. So how does these antimicrobial or antibiotic resistance really happen? So if you look at the statistics, 2.8 million people are infected by antibiotic resistance yearly, and close to 35,000 people die because the antibiotics don't work at the appropriate time and appropriate situation. So if you look at it, why certain patients do not recover from a situation that another patient was much more less exposed to the antibiotic, recovered, this could be the reason. So the alarming status is that by 2050 they are anticipating close to 10 million deaths. That's only a projected number. It's not a hopefully we don't get to that. So 10 million deaths just from antibiotic resistance. So we're talking about 21 years of no discovery to another 30 years of no discovery. So 50 years of no discovery is going to put us back to the pre-penicillin time period. So where we're going to deal with a different animal together. So close to 50% of the prescription from healthcare workers are not optimally prescribed. So that number from 30 to 50 seems to be a global number. It's not just in one country. So it happens in the US, it happens in the UK, it happens in the developed nations, it happens in the developing nations. So that number is kind of pretty much same. And, that is a number that we need to start working on to see if we can bring it down. So as you all know, this picture is self-explanatory, where you see a lot of bacteria and you have one resistant super kind of a bug that actually resistant to the infection and the antibiotic, and does not get destroyed, and then they become superbugs and they become larger, they become populating and taking over the entire area, and then that particular genomic sequence in the bacteria starts transmitting to the other bacteria and mutating them. So that's another problem. So mutation of bacteria is also a trouble. Like how we heard, we've been hearing more of mutation of the virus that's been happening. Mutation of bacteria is also a concern because they become more resistant to any kind of therapy. And then we probably have to invent, go for advanced, therapeutics to tackle that situation. Keeping the comorbid conditions also pretty low. So this is the timeline that I was able to retrieve. I was talking about the antibiotic. You can clearly see that penicillin was discovered in 1928, and then you have the cephalosporins in 48, and then macrolides, that azithromycin medication came in 52. So again, we are still using the same group of medications, pre 50 era. The newer generations that we kind of use in our maxillofacial, oral health, dental health would be, the post 50s would be your quinolones, and some carbapenems are actually are the ones which have been used in higher maxillofacial setting. So the last discovery actually happened in 1987. So and the 1998 was the official welcome of there was another group of medication that came in, and after that there's nothing been developed or researched or grown. So that's a concern in for us, looking at the timeline. So we're already in 20. This was taken in 2010. Look at it, we're in 2021. So we're already 2021, 11 years back now. So another. So basically, we are out for like 21 years. We don't have anything going on. So let's look into the data and statistics. I wanted to get some numbers from how we are prescribing, antibiotics. So in different groups in different parts of the world. So some data from the England, from UK, the dentist prescribe accounts for 10.8% of all antibiotics, and they predominantly prescribe amoxicillin. And the second major medication is the metronidazole. In the US, it's a little bit on the other side. The predominant medication that we use for all dental procedures would be amoxicillin, and the second choice would be clindamycin, not metronidazole. So the data would vary a little bit. There was a study looking back from 1996 to 2013 by a group in British Columbia, showed that the increase of broad spectrum antibiotics went up by 62.2% from dentist standpoint. So dentists prescribed more broad spectrum antibiotics in the span of what is that? In the span of 15 to 17 years, whereas the physicians reduced the use of broad spectrum antibiotics by 18.2%. So that shows that we have to go towards the narrow spectrum. So we've always been taught in the dental schools, we've always been taught in the programs that you always start with the broad spectrum and then you come back to a narrow spectrum to see what's going on. But probably loss to follow from the patient and difficulty in getting the patients back to switch back to the narrow spectrum makes it very hard for us to do that particular switching. So the broad spectrum usage of antibiotic has been causing a lot of resistance, leading to superbug development. So let's look into data from Germany. So they did a study in an oral surgery clinic setting, in both like in a dental setting and in an oral surgery setting in a hospital. So again, you see the resistance developed for Streptococcus species. You see equal amount of resistance have developed for clindamycin and macrolide, like azithromycin, erythromycin, both in the dental setting and in the hospital setting. So that is the amount of in fact, the number of macrolides is more resistant in the dental setting from a dentist office being prescribed antibiotics compared to a hospital setting. And for a staph organism, so the penicillin and the aminopenicillins have shown almost, fairly close resistance developed between the hospital and dental practice. So the light blue bars are resistance developed from a dental practice by prescribing antibiotics. The dark blue bars are the hospital-based cases that have been reported. So I was able to look into a study published from a group in India. I think this was done in a college in Calcutta. So here they have done a survey-based study, and a very interesting study, and they were able to find out that younger generation of dentists did not really have that awareness to judiciously prescribe antibiotics. So that's another point to be taken. I think if younger generation of dentists are not following this particular prescription methods of antibiotics, so then we may have to revisit the education in the dental schools, which we have been having the same issues in the US too. So there has been a disconnect between the the community level antibiotic stewardness towards an academic institution to a dental student. So from a faculty to dental student. So that shows that there are a lot of they were not aware of the resistance happening. They were not aware the need to be judicious or be careful and prescribe antibiotics in dentistry. So the studies and the work for preventing this is happening all over the world. All countries are having their own unique programs. All parts of the countries also are striving hard. The good thing we see that, or the warming thing we see that, is that dentists do play an integral role in this, and we take it as an upper hand compared to our other colleagues. So that is good, because we are 10% of the total prescribers, we could be lower than that. So we could manage it much more efficiently than the other bigger, fraternities. So this was the an ad I picked up from Times of India. So which is showing that 75% of Indians in a WHO survey thought incorrectly that cold and flu can be treated with antibiotics. So that's the first thing. So whenever we see somebody coughing or with cold, it's a traditional thing that to hear from our, even from my family members. When I, for example, if I'm coughing and if I'm sneezing, if I'm having a little bit of fever, which I recently had, the first thing my father said was, "Did you take the antibiotics?" So he didn't even ask whether it was a viral symptom or whether it's a bacterial symptom. So we always go with the antibiotic. It's like it's a go-to drug, and only 58% of the respondents knew that they should stop taking antibiotics only when they finish the course as prescribed. So most of them are already, by default, gets this particular script of antibiotic whenever they visit a physician, assuming then there is an associated, secondary infection going on, but not by, confirming that the patients are having a secondary infection, not, in a case where a viral condition is going on. So that is something to be aware, and something to be very careful to look into, so that we don't abuse the antibiotic regimen. So what is required to develop an antibiotic stewardship program? So most of the systems already have antibiotic stewardship programs. So some systems are much stronger. Some systems are need to be developed furthermore. So what could be developed from our healthcare sector? So antibiotic stewardship is an effort, one, to measure the antibiotic prescribing, to document your antibiotic prescribing. Also to improve, the prescribing, decision making by for clinicians and the use by patients, so that they're only prescribed when they are really needed. So very careful planning and prescribing. Third is to avoid misdiagnosis or minimize misdiagnosis, or delay the diagnosis. Leads to underuse of antibiotics. Um, like, you don't have to right away start an empirical broad spectrum antibiotic when you see somebody having, for example, let's say you have a patient in your office, and patient says, "I have pain in particular tooth," and you don't see any particular signs of infection. So what are the common signs of infections? You see swelling, you see fever. So if you don't see that, you don't have to right away start jumping to prescribe antibiotics. You can delay the diagnosis. You can delay the use of antibiotics. You can say that I'm going to wait and watch. Yeah, there are some downsides to it. Patients are not going to be convinced. That's the traditional, mental makeup patients have. Patients don't want to come back to visit the same office twice for the same problem, because they think they're it adds burdens to their time, and the patients also think that, oh, why don't we go ahead and start it, and if there is an infection, it'll take care. If not, it's okay. So that's the attitude from the patient itself. So that's always a problem. So we've had the same issues here in the US too, and we've had patients saying that, oh, this particular doctor did not give me antibiotic. That's the reason why I came back with pain and discomfort. So, but they don't understand the fact that we are trying to help them by preventing such resistance, which they really don't are not facing those conditions right now. And the last point is to ensure the right drug dosage and the duration are selected when an antibiotic is needed. So the duration is something I want to address in the future slides, because we've had a lot of variations, being published in different studies, and it is not very specific. It's not very, mentioned uh, clearly that this is the amount of duration that you need to prescribe. So the CDC has put up, like four main core elements in an outpatient antibiotic stewardship program. So I'm only going to focus on the outpatient. I'm not going to be talking on the hospital-based setup. So because we are, as dentists, we deal majority with ambulatory care and outpatient setup. So I want to focus on this. So the first, the parameter proposed by CDC is the commitment, to demonstrate dedication and accountability in optimizing antibiotic prescribing for both from the physician side or the oral physician side or dentist side to a patient safety. And the second is the action of policy and practice. So, what is the policy, in place, and how can that particular protocol can be improved on this? The third would be the tracking and reporting is the most challenging one. In fact, I am in the state of Missouri, and in the state of Missouri, there is no prescription tracking software or a method. So, and we've been lobbying, the government, the state government, for us to install one. So, I was in the previous state, before coming to Missouri. I was in Michigan, and Michigan had a good, strong prescription monitoring system. But again, they did come a little bit late compared to the other states like New York and California and other states. So, one, it is, I don't know what is actually preventing it from bringing such a system in place. But the St. Louis area that I work, there's a metropolitan St. Louis area where I work, which is about, say, 25 to 30 miles in radius, that has a separate prescription monitoring system. So, what does a prescription monitoring system do? So, is that, for example, if I'm a prescriber A and I prescribe a patient amoxicillin 500, and I prescribe a patient with for example, a stronger pain medication because I did a surgical procedure that involves a narcotic medication, like say, like a codeine medication. And this particular patient can easily go to a different provider and get a similar prescription with the same complaint or a follow or persisting complaint. It could be intentional, it could be non-intentional. But that particular when the prescriber B goes and prescribes, if he's if he's enrolled in particular like a prescription monitoring system, there would be a red flag that will pop up on the computer saying that, hey, listen, this particular patient already had a prescription taken last week for the same problem, but with the provider A, but you are a provider B, and are you still sure that you want to prescribe this particular patient this group of medication? So that's actually a warning symbol or warning sign to a um, to a prescribing clinician, so that they can make a judgmental call based on how they want to prescribe and whether they want to still go ahead and prescribe and then record the prescription rather than not being recorded. So it's a very important tool for us clinicians to be on track on that. So in the hospital setting, it's much more stringent. So, for example, in a major hospital, if I want to prescribe a certain antibiotic for an oral maxillofacial region, I have only given certain group of drugs that I can access. For example, if I want to access a group of medication outside that boundary, that needs to be sent to an antibiotic stewardship program committee, and then they have to approve my request, for prescribing that medication, and then only I'll be able to prescribe that drug. So that has to be looked. The committee has pharmacists. The committee has infection disease control specialists. The committee has from different specialty questioning my clinical judgment and prescribing judgment. So just to make sure that we are not abusing that particular medication just because it did not prove to be effective. So we'll look into those parameters in the future slides. And of course, the education and expertise improvement among the clinicians and healthcare provider plays a very important role. So these four elements, can be implemented both in a private dental office setting, can be implemented in a institutional setting, or in a community-based or a community health center-based setting. So it's just a matter of establishing these protocols. So what happens in the commitment? So write and display public commitments in support of antibiotic stewardship. Let the patients know that we are striving so hard to take care of them, not just by randomly prescribing some antibiotic. Identify a single leader that is, within the facility. So, like appointing somebody in the in the institution that could be a monitor to spearhead growth of that particular program, and also and create a position for that antibiotic stewardship director, like a person who will monitor that and who will actually come up to you and say, hey, you inadvertently prescribe this medication to this patient and we don't think as a committee was required. So we can make them question your judgment, so you are much more aware of what's going on, and also communicate with all the clinic staff members to set the patient expectations. That's an important thing, to keep our patients happy. So the policy making and practice. So use evidence-based diagnostic criteria and and treatment recommendations. So constantly update the policies. Create your own policies for your local surroundings, for your local environment, for your your patient pool, and also use the other international data published to to use that for your particular group of population. As I mentioned, delay the prescribing practice, wait and watch. So that's an old say. We always say, okay, let's wait and watch. So that we don't have to jump into all the procedures the same day we see the patient. If you're not able to jump into the procedure, actually, then let's not jump into the antibiotic. Actually, we have to, if there is, so the current guidelines say that if there is an acute response from a patient, so for example, swelling with pain or just pain, and there is an acute pulpitis, instead of prescribing antibiotics, we could probably do some kind of a pulp extirpation or a pulp exposure to remove the the necrotic pulp, or if we could, if possible, extractions could be performed. Again, extractions are challenging to perform when you have an active infection going on. Again, if there's an active infection going on, the story changes. So then you have to perform the incision and drainage. Again, you don't need an antibiotic when you perform an IND. So IND is basically done to release the pressure when a patient has a swelling, and also to allow that particular environment to change from an aerobic to an anaerobic, from an environment. So antibiotic does minimal, doesn't do anything in that particular situation, rather than causing resistance for that particular group. The third point would be, written justification in the record. So make sure, for example, you still want to prescribe an antibiotic to a patient who does not have any signs of clinical infection, but just has pain, for example. So justify it and just make a note that a person who's going to be treating the patient later on is aware of that particular condition. As I mentioned to you, the tracking and reporting is a very integral part. Developing individual state monitoring system or a national monitoring system would actually reduce the antibiotic abuse. Not only antibiotic abuse, even the the pain medication abuse. And I am I am aware, because I was practicing in Madras before I moved to the US, and how patients can, in India, we can approach a pharmacy with the help of a pharmacist and get a medication. So in other countries, that is much more stringent, and there are group of medication that is accessible for the patients over the counter that are shown to be, causing less impact. I wouldn't say no impact, because, for example, let's take acetaminophen or paracetamol. So in the US, it is available over the counter. But any abuse of acetaminophen or paracetamol more than 2,400 milligrams per day has shown to impair your liver. So any medication comes with the baggage of toxicity. So it is the how we use it. And acetaminophen and ibuprofen in the US are, I would say, are abused, basically, because you go to a large box store where they sell you in a big tub of medication. No questions asked. Who can buy? They can buy as many as possible. They can take as many as possible and continue their day-to-day work. But we as a clinician, when the same patient comes back to us for care, and when you want to really prescribe, okay, I did a third molar surgery and I did a deep impacted third molar, and I want to prescribe an ibuprofen because it's an anti-inflammatory, right? I want that to be the primary source of medication, not my narcotic. But the patient says, "Oh, doc, ibuprofen doesn't work for me." So how did you come to know? Oh, I've been using it for the last 10 years on a daily basis. So for my day-to-day work, you're not supposed to be using that for day-to-day work. So that is again an abuse. So now we are kind of cornered when we really want to use those medications. So same applies to other groups of medication, not just antibiotic, even opioid stewardship or like a anti-inflammatory stewardship. Education expertise is an important part. So like for example, what we are doing right now is a CE update. What we are trying to discuss is what is going to help a lot of clinicians, help a lot of dentists, help a lot of young dentists who are going to be in practice to know what is happening around the world in terms of antibiotic stewardship or microbial stewardship. So, and educate the patients about the potential harm about the abuse of antibiotic treatment. Provide education materials to the patient, to the clinicians, to your peers. Conduct faculty advanced programs in your school so that all the peers are aware of what's happening. And also provide CE both in the state level and in the national level to promote these are all the practice updates, clinical practice updates that are very, very essential, to provide clinicians to make them aware what's happening, in their neighborhood. So not only the dentist office should be involved, because I look at the dentist office as an independent care facility. It is it's actually like the way we provide care and provide treatment and management is almost like a mini nursing home hospital setup. So the antibiotic stewardship always exists in big level one hospitals. That's actually a requirement because we have a standard here, the JCO standard. So I think we have the similar one back in India. And there are different groups that certify hospitals, and those hospital requirements ensure or require antibiotic stewardship in place so that they control this resistance. Acute care hospitals have to be involved. Long-term care facilities, nursing homes have to be involved. State and local health departments have to be involved in this particular programs. Insurance companies, so they also need to be done. So, for example, like I recently, got myself privileges in a hospital, and I had to I have to do an online, like course on antibiotic stewardship, and for me to get the insurance coverage in the hospital, the insurance asked me to give the proof that I did an online training on antibiotic stewardship in the hospital. Otherwise, the insurance company said I won't, cover you. Said they will deny my coverage, so I won't be able to practice in that particular hospital. So it's all interlinked. So that's kind of good in a way. So we are kind of forced to do it, but we are on the safer side when we do it. The community pharmacies and pharmacists, I think, is an important integral part in this particular journey, especially in India, where our chemists has the right to dispense medication. They are authorized to dispense medication under the prescription and guidance of a licensed practitioner, could be a physician or a dentist. But if they go ahead and dispense the medication, uh, without any kind of prescription, that is where the problem starts. So they kind of yield into the patient's request, and they get into this particular dark area of medications being abused. So this is just a a map that I just wanted to show the number of hospitals in the US that adhere to all these elements what we discussed right now. So you can see the varying numbers. It is not standardized. You can see that with the developed hospitals on the west coast. So let me just explain the colors. So the dark blue is actually adhering a rate of 96 to 100%. The ink blue is 90 to 94%. The light blue or the sky blue, you can call it, 84 to 89%. And the light blue is only 70 to 83% adherence rate. So the hospitals, in this is a 2020 statistics. You can see that in Alaska and in some Puerto Rico and in Montana and in state of Washington, they are below 80%. So they are not adhering to this protocol. So every hospital, that doesn't mean that developed nations have a very superior antibiotic stewardship program. So we are not able to keep up with the standard. So some states have a very stringent. For example, the state that I am currently in is Missouri. They are above 90%. Whereas the neighboring state, which is Illinois, which has Chicago in it, they're just 90. So what I'm saying is that the individual hospitals, individual state bodies, the local facilities have a responsibility in creating and adhering and making all our colleagues stick to this particular strong protocols so that we can avoid this particular resistance. And in fact, I was actually, I don't have that slide. Actually, I was reading one interesting article last night. So saying who prescribes the maximum number of antibiotics in the world? Was it the English? Was it the Americans? Was it the Australians? Was it the Japanese? And alarmingly, US prescribes twice the number of antibiotics in an outpatient setting. So one, I think, is because of the long wait times that we have here too. So the patient turnover. So just to keep the patient quiet for the next 3 to 4 weeks, we put them on antibiotic and say, you know what, that will take care of your discomfort, pain, and so and so. And then after that, they'll be able to see you in the office. So that could be an avenue of abusing that particular group of medication. So let's look into the current antibiotic guidelines that exist in dentistry. So we as a dentist prescribe antibiotic prophylactically, and we prescribe antibiotic empirically. We prescribe antibiotic therapeutically. So these are the three ways of providing antibiotics. So I'm sure all clinicians here, dentists here, have a different way of prescribing depending on the particular patient, and some have a empirical prescription based on their practice model. So the most common condition where we prescribe antibiotic is our cardiac patients. So patients who have been diagnosed previously with infective endocarditis, or that's the most important thing, and patients who have a prosthetic cardiac valve, especially if it is a non-porcine valve, that is if it is a valve that is not tissue related, not a tissue valve, because of the increase in the flutter that increases the chances of vegetation formation in the particular in the valves that leads to potentially infect endocarditis. But for a tissue valve, we don't prescribe antibiotics, antibiotic prophylaxis here. In my practice, we don't do that. So patient has, so that's why it's very important when a patient comes to your office and says, I've had a valve replacement done. And my next question is, do you know what kind of valve did you have? Patient says, I don't. Okay, then they may call the cardiologist. And okay, patient says, I know. Okay, so that's good. If you know it, that's good. So sometimes the cardiologist gives them an information card to the patient saying that anytime you have a dental procedure, you need to take an antibiotic prophylaxis, so that particular information stays with the patient. So you can also ask for that particular card. to verify what kind of valve the patient has. So again, so if it is a cardiac valve, prosthetic valve, if the prosthetic valve, then yes. If it's a porcine or tissue valve, you don't need to prophylax the patient. But again, previous endocarditis, yes, you need to, according to the regulations, you still need to prescribe antibiotic prophylaxis. Now, of course, any congenital heart conditions like as ASD, VSD, and the TF, the tetralogy of Fallot. Any cyanotic diseases, so those have to be prescribed as well. Because of the fact that they are incompletely formed, they're not been repaired. So again, these are unrepaired ones. So they're not being repaired, so that increases the flutter and increases the turbulence and causes the vegetation to form, and that's the reason why we need to prescribe antibiotics. Cardiac transplantation patients also receive the antibiotic prophylaxis. We'll look into the prophylaxis detail in the next slide. What are the other common procedures, which the care is recommended and not recommended? So let's look into it. So, especially cardiac patients. So the recommended procedure, the recommended prophylaxis would be when you're performing a restorative care. It has to be very clear. Restorative care when you're doing a gingival manipulation. For example, you're doing a class 1 prep, cavity prep for a class 1 cavity without a rubber dam. You technically don't need to prescribe, you don't need to prescribe an antibiotic for that particular patient. And surgical and non-surgical periodontal procedures and endodontic procedures, oral surgery extraction procedures, all dental procedures involving manipulation of gingival tissue, periapical region, and oral flora. So this particular point here, the manipulation of gingival tissue is kind of vague, I would say, because, for example, let's say a patient goes in for a periodontal evaluation or just an initial evaluation for periodontal pocket measurement, and there is going to be bacteremia. There is no doubt, but the surge of bacteremia in doing a pocket depth evaluation is not going to be as different than the patient brushes the teeth in the morning. The patient is going to have a bleeding in the morning. Patient is going to be using toothpicks in the house after food. So what is the guarantee the patient did not have the same surge of bacteremia in the house and not from the dentist office? So, my argument is that you don't need an antibiotic prophylaxis for cases where you're going to do gingival pocket measurement. Of course, if you want to manipulate the gingiva, you're going to get your device inside to pack the cord, or there's going to be a severe, breach in the particular area. I can understand the bacteremia surge may be higher. So again, this was something I've always been pondered me. In fact, when I was a dental candidate in Detroit, I kind of asked this question to my periodontics professor, and she got offended for the fact that I compared the pocket measurement to what happened with the brushing. So, but then we became close friends afterward. But that's the thought process I think we need to have, because if we start prophylaxing patients every time the patient comes to a dental office, the number of visits that we provide is enormous. So, for example, we see patients every 3 weeks, but if there's a long care required for the patient. So, and we constantly use this antibiotic on a long-term scale. We'll look into the requirements in the next slides. So the dental procedures for which antibiotic is not recommended. Again, injection of local anesthetic through non-infected tissue. So it could be a PDL injection, and we still don't need it. Any dental X-rays, placement of removable prosthetics like removable partial dentures, any appliances from orthodontic standpoint, primary teeth, exfoliation, bleeding resulting from trauma sustained by oral mucosa or lip. So these are typically not required for antibiotic prophylaxis.
Can you little wind up soon?
Sure, yeah.
Yeah. Okay.
So this is a prophylactic antibiotic regime in place. So in patients, for implant placement, for odontogenic infection indication, you have the same regulations of 1 to 2 grams, either one pre-op for 2 to 3 days, and then infective endocarditis prophylaxis, which remains the same and it's not changed, and the regime is also the same. Which is not changed from 2000. I mean, it's changed after 2007, so it's kind of remained the same for quite a while. So in patients with medically complex, compromised patients, then you have no penicillin allergy. Then amoxicillin is the go-to medication. If you have penicillin allergy, it's going to be clindamycin. It's going to be your second choice. We preferably go with clindamycin rather than going to cephalexin and azithromycin. So this is another area where the use of prophylactic antibiotics has been debated. So in 2015, the position paper from JADA came out saying that no antibiotic is recommended for patients who've had prosthetic joint replacement. However, the decision to prescribe antibiotics still lies with the orthopedic surgeon and the patient, depending on when the particular surgery was done. So that is the clause that still exists. So education and expertise, as I mentioned to you, antibiotics don't cure toothaches. Implementation of shared decision making is very important. Coordination with other healthcare professionals is equally important. So we have to talk among our medical peers and and pharmacists and pharmacy peers to make sure that we do not unnecessarily prescribe antibiotics. So therapeutic guidelines is make an accurate diagnosis, appropriate antibiotics and dosing schedules, prefer narrow spectrum antibiotics when possible, avoid unnecessary use, especially when you know it's a viral infection, treat it empirically and revise the treatment based on test results, obtain knowledge of side effect risks, and educate the patient for proper use of drugs. So the question is, when do I even prescribe antibiotics? So if there is a new 2019 guideline for urgent need for acute pulpitis cases, shows that if the patient has pain only, and if the pulp is vital or necrotic, if it is vital, then you just do symptomatic management. No antibiotics is required. Perform the treatment. If it is necrotic and only pain, again, do only pulp extirpation and then perform the treatment, whatever treatment has to be done, like root canal or extraction, but no antibiotic is required. However, if the patient has pain and clinical swelling, that's the important thing. And I also, in our oral surgery perspective, we also look into the febrile nature of the patient, so that many patients don't get checked. We have to check for the temperature. It's one of the 5 cardinal signs. When a patient goes to a physician's office, I get checked for temperature. But why are we not checking it? We should be checking that. So febrile nature of patients will indicate antibiotic. So if there is an allergy to penicillin, of course, you switch to the narrow spectrum or clindamycin. That's the choice, and or azithromycin would be the choice. So why are dentists important in the stewardship program, and how can you be involved? So we prescribe 10% of all antibiotic prescriptions, and we have to put in our guidelines in our forte area and review the current guidelines for prophylaxis, for treatment, for infection, and also empirical and prophylactic as well. Unnecessary use of antibiotic in dental setting may lead to unintended consequences for patient, and communicate with patients about why antibiotic may not be necessary in their best interest. So we've only been talking one spectrum of antibiotic resistance. We have not been talking the other spectrum. The other spectrum is behind the wall. So one spectrum is that we prescribe antibiotics, make the patients consume the antibiotic, and develop a resistant bug in their gut. However, on the other side, the veterinary group is something that is not being discussed. So as I mentioned to you in the past, we only spoke about physicians, pharmacies. We should also be including our veterinary colleagues. Veterinary colleagues have also been prescribing similar group of antibiotics, one for the sustaining of the food industry and one for the sustaining the livestock. They also develop antibiotic resistant superbugs in their gut, which gets transferred to the food. And when these two combinations, food and the patients with the resistant bacteria together, create a much more stronger resistant, genetically modified resistant bacteria in general public. So this spread among the community is much more silent and quieter compared to just the antibiotic issues. So, what are the causes of antibiotic resistance? Overprescribing antibiotics, patients not finishing their treatment for the prescribed antibiotics, overuse of antibiotics in livestock and fish farming, poor infection control protocols in hospitals and clinics, lack of hygiene and sanitation, and lack of new antibiotics being developed. So, again, coming back to the same core crux problem. So, what can we do? So, use only antibiotics when prescribed by certified health professionals. Always take full prescription, even if you feel better. Never use leftover prescriptions. Please don't share it with your other family members, and also prevent infection by again same basic principles of infection control. Wash your hands, avoid contact when sick people, and keep your vaccinations up to date. So let's look at the environmental impact of antibiotics. So there was a 65% increase in the drug concentration, projected increase by 2050. And only 8 large R&D companies are actually researching antibiotic in the wastewater system. So Dr. Putaya must have mentioned about the water lines in the dental offices too. So water lines are more important in antibiotic resistance as well. So the research have found out that higher concentration of antibiotics have been discarded in the wastewater system, and two out of three rivers, two-thirds of the world's rivers are all completely contaminated with antibiotics. And if you see that, they say that again, 2050 is the target, saying that it's going to be skyrocketing, the antibiotic resistance in the water system. Another global impact on the human health. So antimicrobial resistance. So only 30% of the developing nations have a plan, have a national plan in place. So cost-wise, it's going to be more than $100 trillion lost by by 2050, and there are 490,000, almost 500,000 cases of multi-drug resistant TB every year. So we are kind of sidelined all these conditions, especially during this pandemic. And you can see this: 7 out of 8 passengers traveling, 87.5 travelers to India returned to Western Europe carrying a drug-resistant bacteria in their gut. So, which is alarming. So that it is going to continue. So what has India done? So India has taken their fair share of effective step. They've collaborated with ICMR and Pfizer, and they have come up with a system similar to what our CDC has launched. And it's an effective system, and they collaborate with CDC in devising protocols and ideas, and and formulating guidelines for clinicians in India. So I'm going to wrap it up pretty soon. So I actually want to talk a little bit of this slide. So during the pandemic, there was an increase in oral candidal infections. And people thought that it was initially an antibiotic, so they started using antibiotic left, right, center. And even though it was a viral situation, that there was a strong neglect for the antibiotic stewardship program, and there is a rising antibiotic resistance because of this pandemic. So this is something to be cautious. So this is like a double whammy, both a viral threat and a bacterial threat, creating a super resistant bacteria. So what are the ways? So the only other way is to not to prescribe antibiotic when you know for sure it is a viral origin. So you can see that 87.7% of hospitals prescribe antibiotic, where only 6.9% were accounted for secondary infection or co-infection. The only way we can fight is to reduce COVID-19 infection and potential unnecessary use of antibiotic, and decrease the likelihood of spreading drug resistance. So if we start working now, so we'll be able to sustain this particular or prevent this resistance. If not, we're going to probably lose every person like every 3 seconds by 2050. So that is what the studies say, that AMR is not tackled now, we're going to lose people. So I like one of the quotes by Walt Disney: the way to get started is actually to quit talking and begin doing. So that's what I'm going to do. I'm going to quit talking and let you all do the same, work, what you're supposed to do in the community. So this is just a takeaway. So AMR, antimicrobial resistance, is a ticking time bomb and can reduce, the dentists can reduce AMR effectively in their offices and initiate programs in their communities and offices. Use antibiotic with caution and be careful of antibiotics, especially in a pandemic. So that's going to be a problem. And wish you all a happy Father's Day. And this is my first Father's Day, and happy Father's Day to each and everybody in this forum today. And I hope you all be safe, and hope to all see in person very soon. And
Thank you.
Thank you again.
Thank you, Prashant. I think wonderfully, talked about antibiotic resistance and antibiotic stewardship. I would just like to highlight some of the salient points you covered in your presentation. Antibiotics are major arsenals, but not effective sometimes, as you said in the beginning. And what is antibiotic stewardship? Actually, it is it's an endeavor where we promote, educate for optimum selection. And when we normally, when we prescribe antibiotics, we forget about optimum selection and we just do it. And, you said that in the last 20 years, there are only 2 antibiotics which we have been able to develop. So, finding a new molecule is so difficult. So, it is very important that we use the existing antibiotics very sparingly. And you also said that we cannot use antibiotics for chronic conditions, and many of our dental conditions could be chronic. So we really need to know what to do, when to use antibiotics. So that has to be very clear. And antibiotic resistance is not only happening in the health sector, it is also helping in non-health sector. You talked about livestock and other areas, environment. It's affecting everywhere. And you said that 50% of antibiotics are prescribed unnecessarily in hospital setting. And 35,000 people die every year because of antibiotic resistance. And the figure is very scary when you said 10 million people are likely to die by 2050. So, we better get our act together and, be aware of antibiotic resistance. And you also give that the very important part of process was that the bugs give their antibiotic resistance to other bacteria, carrying more problem. So, and, you said that dentists prescribe more broad spectrum, and physicians, their broad spectrum use has gone up. That means our diagnosis is not very specific. And, whereas the physicians are using very narrow range antibiotics, and their use of broad spectrum has come down. In India, younger generation especially, not very aware of prescription. So there is a disconnect somewhere between academics and how this is being done. Antibiotics can kill you, through antibiotic resistance. That has to be kept in mind. All those, what is a part of antibiotic stewardship, measure it properly, document it properly. There should not be any misdiagnosis. And 3D is very important: right dose, right drug, and right duration. So 3Ds are very, very important. And I think the core elements of antibiotic stewardship, as highlighted by CDC, communication, policy and practice action, tracking and reporting, and education and expertise. I think these 4 areas one has to emphasize on, and especially when it comes to education. I think it is a responsibility of the associations, educational institutions, organizations like ICD, to make them aware and make the information available to them, so that they are well aware about antibiotic resistance. In future directions, I think ABS, antibiotic stewardship, must be there in all hospitals. I think it should be there before you take a license, to renew your license. So it's a very good idea that they should have an online training on antibiotic resistance. And the chemists in India, they misuse it because they only have a power to dispense and not to prescribe. And many a times, they yield to patient requests and they start prescribing. So current guidelines, you should be using antibiotics only in cardiac conditions, congenital heart condition, cardiac transplants, and in dental settings, wherever there is a tissue manipulation, periodontal, endodontic issues, oral surgery, where there is a bacteremia surge you are expecting, and not to be used if there is a bleeding from trauma and other cases like X-ray, prosto, etc. And no antibiotics are needed before prosthetic joint replacement, and also before implants. Actually, we don't need antibiotics before doing an implantology. Antibiotics do not cure toothache. So whenever you want to use it, use narrow spectrum and have a right diagnosis. That's very important. And you said if the pulp is vital or even necrotic, no antibiotics. If there is a pain, swelling, and patient is febrile, only then use antibiotics. And if at all you want to use it, use narrow spectrum. So why antibiotic stewardship important for us? Because so that we do not unnecessarily prescribe antibiotics in dental setting. Antibiotic resistance can have far-reaching effect. And you talked about livestock, because veterinary surgeons are also prescribing antibiotics. It has impact on the environment and an impact on a global human health. So the takeaway, what is the takeaway? AMR bomb is ticking slowly. We have to be very careful prescribing antibiotics so that we don't face any such situation in future. Congratulations, Prashant, for a wonderful presentation. At this juncture, I invite Raghu Putia to take over and complete the proceeding of today's session. Raghu Putia, please.
Thank you. Yeah.
So I think, it's been long 5 weeks where we have, we all have gathered together to understand dental infection control, and more so today, antimicrobial stewardship. Our only hope is that, we further need to take steps in improving the quality of care for both patients, and also, have occupational safety to be taken care of within a dental clinic. Those are my simple words. There is nothing, there's no fanfare out here. This is one of the most neglected subjects in dentistry. Both the dental infection control and occupational safety, including antimicrobial stewardship. Hopefully, from now on, at least, I wish that we put this into the forefront. Keep it front and center, and look at how can we apply it in our daily lives? How can we improve, dental safety? How can we acquire better materials, materials that will work? How can we avoid being dumped on by international companies where it has not been cleared in other parts of the world, but in India they kind of are selling these things. So that is one. The second thing is, how to implement it in daily lives. When are we going to update our new standards? So it is not just one item, but it's a whole monster sitting in front of us. So hopefully from today onwards, we'll keep it front and center and move on forward. The next thing is to lay a pathway to local experts. Get the local experts trained in multiple experts trained, as key personnel. Because, today, we will be here in America or in some other country and we can consult and help. Tomorrow we are gone. It has to develop from within, and when it develops from within, there is more power and there is more meaning to it, and it becomes more meaningful to the local practice of dental safety, rather than it being translated from another country or dictated by somebody who's loudmouthed and so on. So I leave that to you all, and thank you so much, Dr. Hari Babu, Dr. Mahesh Verma, and Dr. Arpit Gupta, Dr. PC Gupta, and everybody, including Rajesh Chandana, who actually, he has actually been the person behind the screens. He was the one who initiated these programs. One day he calls me and he says, "Well, Raghu, why don't we do this? And let's get this cleared by the head office and go ahead." Now, that's a good thing, but to implement it, hats off to everybody who was involved in in setting up these programs and the series of lectures. Okay, thank you, and have a great Father's Day. I'm sorry I couldn't join in earlier. I was actually driving and I ran into problems with Wi-Fi and so on. But all the best and happy Father's Day to everybody.
Thank you, Raghu.
Thank you, Dr. Raghunath. Thank you, Prashant, for a wonderful presentation.
Thank you, Dr. Chirk, for the opportunity.
Are we wanting to take any questions here at this stage? You have taken up most of I guess the queries which could have come across, you have already attended to those. And
yeah, I'm just looking at the chat box too. I think a lot of comments are,
there are comments related to the antimicrobial therapy and resistance, but I guess you have already told the indications, contraindications, and situations where the use of antibiotics is definitely required and where one could avoid it, and Mahesh also elaborated on those. So if there's no other question, we can move forward. Is there any question? So dear friends, we have had an amazingly wonderful certificate program on infection control and occupational safety in dental practice running into 5 sessions, where Dr. Raghunath Pataya shared his enormous knowledge on the various aspects of dental infections. He very extensively discussed the common infectious diseases and then the rationale for controlling these infections. He apprised us with the emerging diseases and the ongoing pandemic. He elaborated on the various personal protection equipment to be used by the dental professionals and discussed the pros and cons of the many hand care and hand washing protocols need to be followed to avoid the exposure to the infections. The discussion on the various air circulation devices will be very beneficial to all of us. Dr. Raghu talked in detail about the possibilities of infections because of the water system in the operatories. He highlighted the options to avoid any contamination from the water resources. The interactive sessions on sterilization procedures were very well explained by Dr. Raghu. The final session today by Dr. Prashant on the use of antibiotics in dental practice was outstanding. He advocated the judicious use of antibiotics during the various dental procedures. Dr. Prashant shared the safe practices in the use of antibiotics. I take this opportunity to thank everyone associated with the event, President Dr. R.P. Gupta, board members of ICD, especially Dr. Mahesh Verma for conducting the program and his valuable inputs in the many discussions we had at many stages of the session. Dr. R.K. Bali, Dr. Hari Prakash, Dr. Anil Kohli, Dr. D.N. Kapoor, Dr. Rajesh Chandna, Dr. Meera Verma, Dr. S.M. Balaji, Dr. Virmani, Dr. V.S. Kohli, Dr. Vinita Chok, Dr. Vijay Mathur, to name a few I can see right now. I would also like to thank Dr. Krishan Kaba from PGI Chandigarh for blessing this event. I also see many other eminent dental professionals from various parts of the country. Just to name a few, Dr. Sharad Kapoor, Dr. Briggs Agarwal, Dr. Puneet Batra, Dr. Gautam Manjal, Dr. Romil Singhal, Dr. Rohit Shakeen, Dr. Gurvanit Lehal, Dr. G.M. Sogi, Dr. Kumar Rajan, Dr. Vinay Bhardwaj, Dr. Samarth Agarwal, Dr. Varun Bajaj. Please excuse me if I have missed out on any names because of the paucity of time. My special thanks to Dr. Arpit Gupta, Secretary of IDA Chandigarh State Branch, for the enormous effort put in by him in organizing this program. Thank you all, the audience, for joining us in big numbers to make this program a mega hit. If anyone has any interest in being associated with ICD Section 6, please contact me. I am Rajiv Kumar Chuk, Secretary General of ICD Section 6, and my email address is icdsection6@gmail.com. I repeat, icdsection numerical 6@gmail.com. Thank you all for being a part of this program, and we look forward to be associated with you in our future events of ICD and ID Chandigarh State Branch. Thank you. God bless you all.